Good evening, everybody. Welcome to another episode of The Breakdown. It is today, July 21st, 2024. We promised we were going to do we're going to play with the format a little bit for the summer. And we're doing exactly that tonight in a conversation I know I've been looking forward to. I think some of you have as well. We're bringing civility back to debate I dressed up. I put on a little suit coat and everything. Now, before we get into the conversation, this is likely going to get heavy. We have two heavyweights in the sphere, in the public debate, let's say, who are going to be weighing in tonight. And there's a good chance that there's going to be a little bit of spice. Maybe a little bit of the spicy is going to show up. All of that being said, there's a couple of disclosures that we got to get out of the way right out of the gates. I've been told that if I don't plug this up at the front, everybody's going to check out at the end and it would be a waste. So if you like this, if you like the content that we produce, go to our Patreon page, www.patreon.com/thebreakdownab. I'll do a bigger spiel at the end. Just wanted to get that up front. A little bit else that we have to, I have to disclose actually, because we are talking tonight about the opioid crisis, not just in Alberta, not just in BC, but across the entire country. We're going to be talking about possible solutions. We're going to be talking about the differing perspectives on what those solutions should look like. And this is where I got to do because we're talking about things medical and we're talking about things paramedical, I got to do a full disclosure here. So as many of you longtime listeners of the show probably are aware, this is a side gig for me hosting this show. I work full-time as a paramedic here in the province of Alberta in the city of Calgary. I have for almost a decade and a half now. And so I have a lot of very much frontline experience with the opioid crisis and the effects of the opioid crisis. I got to say very, very clearly right out of the gates that anything that I say tonight is my own personal belief and not in any way reflective of the beliefs or positions of my employer. There, I said it. Now you can't get me. Ha. Secondary to that, I also want to make it clear that I do have some medical knowledge and background when it comes to toxidromes and in particular the opioid crisis, but as well, I've worked for a few years now in the mental health and addictions space for first responders with peer support teams and with intervention and mental health stuff as well. So I come with a little bit of a background and honestly a little bit of a bias. We do these disclosures at the beginning of all the medical papers because it's important that people know where we stand. So this is what I'm doing here. All of that being said, enough about me. It's time to bring in the two people that we're here to hear from tonight. First of all, I'm just so excited to have both of these guys on the show. Guy Felicella. He's been on the show a couple times now. I'm going to bring you both in. No talking yet, though, because I got to get through the introductions, and then you can say your things. Guy Felicella has got a day. I don't have a day. I don't know anybody else who has a day. Guy Felicella Day is May 29th in Vancouver. He was given that day for his work in harm reduction recovery and helping families struggling with addiction. He has the Courage to Come Back Award recipient for beating addiction. He's the Van, which I think means Vancouver, unless there's like these vanning magazines that I'm unfamiliar with. I know that a lot of people are living out of vans these days. That's probably relevant to the conversation that we're going to have tonight. But Van Magazine Top Power 50 list of inspiring people. He is a 2 times TEDx speaker. He has over 11 years sober. And that alone makes him a very unique individual. We're going to have some statistics on that later. He's a fierce advocate for both harm reduction and recovery. He's an and guy, not an or guy. Guy Felicella, welcome to the show. Thank you so much for taking the time to have this chat with us tonight.
Thanks for having me.
There we go. Okay. Adam Zivo is a writer, world traveler. His pinned tweet is pretty telling. I still call them tweets. Deal with it, Elon. He's a writer, has bylines in the National Post. He's written for the Epoch Times and the Western Standard. By the way, July 24th, warm up the Orville Redenbachers. Derek Fildebrandt's first day in court for threatening the lives of children. So excited. Adam Zivo has an advocacy record that includes his role as a founder and director for Love is Love is Love, an advocacy campaign in support of the LGBTQ2S plus community, as well as recently became the founder for the Center for Responsible Drug Policy, which advocates for strategies to address addiction while condemning safe supply, as well as is the founder of the Substack Break the Needle, both of which are very ideologically in line with his stated goal of, and Adam said this, burning the safer supply system to the ground, and his stated belief that safer supply is a scam. Both of these men regularly tweet at each other on the Twitter machine. And tonight, we're here to try to have a conversation about why each of these fierce and passionate advocates hold two radically different views on the crisis facing Canadians. Adam, thank you so much for coming on the show as well, sir.
Oh, thank you for having me, and thank you for that neutral and balanced introduction.
Well, that's what we do here. I loaded my. I think everything I said was factual, wasn't it?
Well, I think that some of the way that you framed it was misleading. I've done 3 articles for the Epoch Times, which is the same that I've done for Extra Magazine. I don't necessarily endorse the editorial perspectives of the newspapers that I submit to, nor do I have any real affiliation with the Epoch Times aside from a few freelance pieces.
Okay, cool. Well, good disclaimer.
Yeah. So there's that.
Yeah, I don't have a problem with that. Here's the rules of engagement.
Okay. Yeah. Sorry. Go ahead.
No, I want to get through the rules of engagement, and then you can say all of the other things that I said. And I don't know who's dinging, but.
Oh, sorry.
I feel I haven't sworn yet, so I don't know why I'm being beeped out. Rules of engagement. So tonight we're trying to have a conversation based on the evidence and the science. With that being said, anecdotes are acceptable. Anecdotes are a great way of telling stories, but they're terrible data for policy decisions. Anecdotes appeal to emotion, and where the saying is, there's truth to the saying, where there's smoke, there's fire. If you're only aiming for the smoke, odds are good you're going to miss the fire. So if anybody has any statistical claims, we're going to have to ask them to back them up with receipts. All of that being said, Adam, you had a couple things you wanted to add before I move on.
Well, I mean, when it comes to the comment about burning the system to the ground, I stand firmly behind my desire to burn the system of diversion to the ground, much as any investigative journalist working on the OxyContin crisis 20 years ago would have felt similarly with respect to corruption and diversion with Purdue Pharma at that time.
Okay. So just to be clear, you don't want to burn the safer supply system to the ground.
I think that bad policy should be held accountable. I think that criminal enterprises that profit off bad policies should be criticized. I think that there is a role for safer supply in the addiction space if implemented responsibly, but I don't think that the current model that we're seeing in BC is responsible.
Okay, good clarification. We're going to start with one of the criticisms that often is made in regards to conversations around highly polarizing issues is that people on different sides of the spectrum no longer have a shared reality. So in order to try to define something of a shared reality for tonight, I'm going to ask, I think I've got 9 questions. They're brief. They pretty much should be, hopefully, yes or no questions to determine what page are we on. Are we starting from, and to make sure that in this conversation tonight that we're starting from the same page. So, first question, I'm going to throw it to Guy first. I'll bounce back and forth between the two of you. Can we agree that there are concerns that there is a toxic supply problem and an addictions problem, and that they are separate but related? Guy, is that a statement that you can get on board with?
100%.
Perfect. Adam?
Yes. 100%.
Excellent. Can we agree that 2 of the biggest predisposers to addiction are trauma and undiagnosed mental health issues? Adam?
Yes, of course.
Guy?
Yeah, 100%. And I'd also throw in poverty as well is a huge factor for people to gravitate to substances as a way of a distraction from unaddressed societal issues.
Point taken. Can we agree that addiction often both has physical and psychological components directly related to the drug that the person is addicted to. The example that I want to use before I let you each answer is something like alcohol withdrawal, where if somebody decides to stop drinking immediately, they can have seizures and they can die from those seizures. Very often, those people are treated with benzodiazepines to keep them from having those seizures. That has nothing to do with the choices or their mental state. It has to do with the physiological piece. So can we all agree that there's both a psychological and a physiological component to addiction?
Yeah, of course.
I would agree with that. Yep.
Perfect. We're making good time on here. Can we agree that the toxic supply affects both recreational users and people who have a physical dependency on drugs? Guy?
Oh, I think it impacts all walks of lives, even intermittent substance users, first time experimental drug use. I mean, here the risks are catastrophic for people in today's day and age. And it's the unregulated toxic drug supply that is the defining factor that's killing people, not in just the country of Canada, but also North America.
Okay. Adam?
I mean, to answer your question simply, yes.
Perfect.
Highly toxic drugs, very dangerous to recreational users or to people who are physically dependent on them. Seems obvious.
Excellent. Can we agree that many of the opioids that we're going to be discussing tonight do have legitimate medical uses? And for the vast majority of drugs, the poison is in the quality and the dose. Adam?
Yeah, I guess you can say that.
Okay. Guy?
Yep.
We're getting along already. There's so much we share. Can we agree that recovery is a broad term and what recovery looks like will vastly differ for some different individuals? I want to refer to a study that came out from the Philadelphia Department of Behavioral Health and Intellectual Disability Services and the Great Lakes Addiction Technology Transfer Center that found that on average, at the time of the study, when they did their initial review, but since then they've updated, 49.9% of people who are in the general population who once met lifetime criteria for substance use disorders, an average of 49.9% no longer meet those criteria. In community studies reporting both remission rates and abstinence rates for substance use disorders, an average of 43.5% of people who have ever had those disorders achieved complete remission, but only 17.9% did so through a strategy of complete abstinence. I bring up those statistics to try to underline the point that recovery does look different for different people depending on where they are in the continuum of recovery. Can we all agree that that's a thing, Guy?
100%.
Adam?
Yeah, I'd agree. I mean, we had the conversation about medically assisted therapy decades ago, and we resulted in favor of accepting the fact that, yes, you can use some opioids to assist people on their path to recovery.
Perfect. Can we agree that recovery is just kind of bouncing off the last one, but can we agree that recovery is a continuum that a person can move both backwards and forwards on? Adam?
Yeah, of course. And understanding that is necessary for having a compassionate approach to addiction.
Guy?
Yeah, I mean, it's people are trying.
Can we agree, given all of this, and the evidence shows that at best abstinence recovery is only effective for roughly 20% of the population, and only 50% of the population will achieve remission? A strategy, not saying what the strategy, whether it's I hope it's not a single one, but the strategy that's required is going to be needed to protect those who are not in that 50% of the population who will achieve remission. Adam, can you agree with that?
I can agree with that.
Guy?
Yeah, most definitely. It's a chronic relapsing condition and one that impacts, so many of us. So, yeah.
Perfect. There we go. See, look, we agree on everything so far. This is it's the code, isn't it? The audio listeners aren't really going to get that joke very well. Broad questions. Here's the topics. And the way that we're going to structure this is I'm going to ask a broad question for your perspective on it. One of you is going to answer first, the other one will answer second, and then we'll give a bunch of time for debate or discussion, if you will. If anybody gets out of hand, I've got all the little control-y buttons on the side over here. And I'm wearing the fancy coat. Let's do the civility thing. So let's try not to interrupt each other too much. Let's try to have an organic, flowing conversation. So to start with, Mr. Felicella, I'd like to hear your thoughts on the different types of drugs that are involved in the drug crisis.
Well, anything that's unregulated, obviously, that's what's killing people in our society. It's just unpredictable and volatile. But there's also, as well, and there's always been access to pharmaceutical substances as well. The unfortunate reality in today's day and age, though, is that nowadays I would encourage anybody who is buying either or off the streets that to have your drugs checked, because it's just that unpredictable. And, it might not be obvious to many people. I can spot counterfeits all the time, but I don't believe a lot of people can. And so it's really important that everybody understands that unregulated drug supply is the deadliest thing that we are dealing with in the crisis today.
All right. Mr. Zivo, can I call you Mr. Zivo?
Yeah, that's okay.
Cool. Mr. Zivo, what are your thoughts on the different types of drugs? What do people need to know about the different types of drugs that are impacting Canadians' lives?
Well, I think obviously we need to focus on opioids since they drive the majority of deaths. At the same time, I think that the framing often used in this discussion is counterproductive. We talk about unregulated drugs and quote unquote toxic drugs as if legal drugs, legal pharmaceuticals are in some way non-toxic. We have to recognize the fact that safe pharmaceutical drugs are a very dangerous gateway into deeper levels of addiction, and that these pharmaceuticals are the reason why we have an addiction crisis, or rather an opioid crisis in North America to begin with. Let us not forget that before the 1990s, we didn't have a significant opioid issue in North America, but unfortunately we changed our prescribing practices and we normalized the overprescribing of opioids, largely due to pharmaceutical companies that wanted to make money off selling these drugs. And they flooded into our streets. They caused a wave of addiction. We tried to clamp down on them. Unfortunately, we didn't have a plan in place on how to transition people off of pharmaceuticals. And now we have this horrifying, crisis where, yes, most people are dying from fentanyl. Most people are dying from illicit supply. But we seem to have fixated so much on that aspect that we've forgotten the dangers of pharmaceuticals and how they get people into the illicit supply. And I think that's a very important piece that some policymakers are trying to ignore to everyone's detriment.
Okay. I got one quick question, one point of clarification that I want to ask you there, Adam, and then I'll get out of the way and you two can respond to each other's points. When you say there was no real crisis with opioids until there was heavy prescription, I just want to clarify, are you referring to sort of the advent of OxyContin?
Yes, so it's the OxyContin crisis. Prior to OxyContin, opioids were mostly limited to a small number of heroin users in urban centers. This was very well documented by Sam Cahota's book Dreamland, which came out in 2015, as well as Empire of Pain. It was difficult to access opioids and they were stigmatized. And then, of course, you have Purdue Pharma coming in and telling people that pharmaceutical opioids are quote unquote safe, falsely claiming that only less than 1% of users develop an addiction from them. So doctors were told that it was compassionate to provide these opioids easily, because otherwise you were denying pain patients humane care. And unfortunately, organized crime took advantage of this. And suddenly you had millions upon millions of OxyContin pills and other similar pills flooding into communities and getting people addicted, all under this rhetoric that was compassionate to overprescribe.
So can I just ask then, OxyContin was created and received FDA approval in 1995.
Yes.
BC flagged opioid deaths. The province of BC flagged opioid deaths as a critical problem in 1993. So I don't think that anybody in this conversation tonight would make the argument that OxyContin contributed in horrifying and terrible ways to the explosive growth in opioids. But I do think it's important to highlight, like even Tylenol 3s were first put to market in the 70s. There's been lots of opioids that have been prescribed, and there's been lots of concern with opioids prior to oxycodone. So I think it's important to have the historical accuracy correct in that before I get out of the way and let you guys go.
I don't think you can compare. You can't compare the 90s crisis to today's crisis. It's just it's completely different. That was marketed completely different from doctors and Purdue, and everybody else was told these are non-addictive drugs, prescribe them. Yeah, sure. It's a cash grab and a money grab for these massive pharmaceutical companies in the 90s. But however, in Canada, the drug supply that's always been impacting people has been the unregulated market. And if you look at the stability from the 90s right up until 2013, our overdose numbers of people dying per year were roughly around 250 people, except for in 1998 when we did have a declared public health emergency, actually a dual declared public health emergency, which was the HIV/AIDS crisis in the downtown east side, and also the toxic drug crisis as well. And that shifted. In today's crisis, I mean, in 2012, the percentage of people, 2012 and 2013, the percentage of people dying from heroin was significant. There was only, I believe, about I think it was between 8 to 14%. I don't really have the data here, but it's not much higher. And then if you look at 10 years now from later, it's 88%. I mean, it's astronomical. In 2012 off heroin until 2012 and 2013. And when I actually look back on it, that's when that supply started to change. And so we didn't have all the tools in place like drug checking, or naloxone kits weren't on the street. And now the way it is, I mean, people are dying from that market. And I also go against what Adam's just saying about, sure, pharmaceutical drugs can cause damage. All drugs can cause harms to people, but however, they aren't the motivating factor in people gravitating to fentanyl. And if I've spoken in so many schools over the last, 8 years, and I've never had somebody say to me, I started with using hydromorphone. It was always the drug, alcohol, cannabis, ecstasy, those types of substances that people gravitate to. And then, you know what? It's some people are predisposed to develop addiction patterns depending on the other circumstances in their lives, such as childhood trauma, foster home, poverty, those types of things. Those are the things that motivate you to use these substances. And sadly, today, that's what gets people to these, unregulated drugs. It's not the safer supply programs. Sure. I mean, for me as a substance user, I wanted to function and use substances and do things. And that's what I did. Today, what I see is that a lot of people who are struggling with the toxic drug supply, unfortunately, because it's cut with nitzenes, benzos, xylazine, vet drugs, they just leave people kind of in this, sad state where they aren't able to do things. So it's really hard for me to watch people use these substances and not be motivated to do anything, other than wake up and do more. I just think there's a lot of unaddressed societal issues that have to come before we can actually move people down a continuum of care.
Adam, what do you got on that?
Well, I mean, you say that you've never spoken to someone who's initiated an opiate addiction due to hydromorphone. I have spoken with a number of people who have gone up that ladder, including youth in BC and a number of adults in Ontario, as well as dozens of addiction physicians who are reporting seeing this in their practices. So I don't know the kind of people who you're speaking with, but the interviews that I've dealt with have very much seen this as a big problem. Now, I agree with you. We should address the underlying reasons why people use substances. We should have better investments in mental health programs. We should have better housing supports. We should have better social supports. However, we don't have that. We unfortunately tend to neglect people who are disadvantaged in our society, and we should fix that. But until we do, there is going to be a subpopulation within Canada that is highly vulnerable and a population that is looking to medicate in some way to deal with the fact that they've been left behind. And I think that if you have people who are looking to self-medicate because of their mental health trauma, because of their social exclusion, it is the most responsible thing to do is to ensure that it is not easy for them to access substances which can destroy their lives and initiate a path of addiction that eventually leads into fatal fentanyl use. It's a well-accepted fact within the addiction medicine world that drug use, well, use of a drug increases as a drug becomes more abundant, affordable, and its perception of threat decreases. And this is what we are seeing with safer supply and with hydromorphone. And I think that that is deeply concerning, and that some people are underplaying that problem and underplaying how hydromorphone fits into the overall ecosystem of addiction that once again terminates in fentanyl deaths.
I got a question if I want to ask, because you've spoken, Adam, about these interviews, and it would seem to me that if there was an increase in youths who were becoming addicted to opioids opioid use disorder due to particularly hydromorphone, that would be reflected in the statistics. Ontario statistics are really, really hard to find, but BC has actually done an amazing job of documenting their statistics. We were able to pull up the numbers by age of who's getting diagnosed with opioid use disorder. And the numbers for people under the age of 19 are incredibly static. There's a little bit of ups and downs here and there with summer and winter, but for the most part, the numbers themselves for people under the age, they call them youth under 24, I believe it is. But among youth under 19, the incidence rates, I'll read right from the graph here, the incident rate has remained stable and low from January 2010 to September of 2022. So there's no growth to reflect the kind of thing that you're talking about in your interviews. And I'm not saying that your interviewers are lying or anything like that. I'm just curious how you reconcile the statistics with what you're hearing.
Sure. So I'll bring up 4 specific things here. So first of all, addiction is a lagging indicator, right? So safer supply only became widely available in 2020. The kids who are accessing hydromorphone and developing addiction will take several years to go to a doctor and say, I am now addicted to opioids, right? So we can expect some kind of spike to happen, but not immediately. Second of all, diagnosis rates for opioid use disorder don't necessarily capture the full degree of addiction that's happening within society, because you have to have the capacity to diagnose people. And we all know that BC's healthcare system has been exceptionally strained since the pandemic. So if people can't access a family doctor to get basic care, how can we expect them to go to a doctor to be addicted for opioid use disorder? That's 2 parts there. Now, the 2 other parts I want to bring up are counter statistics. So let's look at the youth drug deaths between 2017 and 2023. So, Lisa LaPointe released this report last summer, and she basically framed this in a super, super misleading and deceptive way. So she said, we're going to release this report, we're going to look at youth drug deaths, and we're going to emphasize the fact that only 8% of youth had hydromorphone in their system when they died of drug overdoses between 2017 and 2022. But however, safer supply was not widely available in 2020. So to frame it this way is like saying, well, we averaged out car deaths between 1750 and 2024, and we found on average that they were really low, therefore cars are not dangerous, right? You have this really large beginning period where the factor that's being analyzed just wasn't really in play. But when you break down the numbers year by year, so 0% of youth drug deaths involved hydromorphone in 2017, 0% in 2018, 0% in 2019. Safer supply becomes available in 2020. That goes up to 5.5%. 2021 goes up to 9.6%. 2022 goes up to 22.2%. So within 3 years, we went from 0% of youth having hydromorphone in systems when they die from drug toxicity to 22.2%. That's really concerning. And this is consistent with the hypothesis that youth are accessing diverted hydromorphone and then graduating onto fentanyl, which kills them. Now, the second stat that I want to bring up
Can I just jump in for a quick sec? Because I want to understand something. If somebody's graduating from hydromorphone to fentanyl, why do they still have hydromorphone in their system?
It's a good question. That part you can think of like kids who are graduating onto fentanyl and haven't fully made that transition, and that might be at the time when they're most vulnerable of overdose, right? So you have a kid, for example, who is just beginning to use fentanyl, and that's when they're most likely to die. So I interviewed a few kids, Camilla Sword and her friends who were representative of this case. Some of her friends had begun, using dillies, and then they continued to use dillies as they transitioned to fentanyl, and then they overdosed. So that's concerning.
It can
also let Guy jump in.
It can also be counterfeit substances as well. I mean, there's a lot of counterfeit drugs on the street too. And the one thing that is very challenging for me is that what was the first drug that people started? And it's interesting that nobody talks about that as being the factor in the progression of people who are struggling with addiction. And it wasn't hydromorphone. I've never even met an opioid user that started using opioids unless it was somebody that had maybe a surgery or something and started with it, and then after that. But I've just never met somebody that was absolutely started just buying hydromorphone off the street.
You want to know what? Can I give you an advice? So you should go to Nanaimo, and there is
I was just in Nanaimo.
Yeah, so I'll call some of the kids who I interviewed. They can meet you. There's a Subway restaurant, which is just outside of one of the schools. I forget the exact name, and they can tell you all about how all of their friends started using hydromorphone as their first opioid because it was so abundant and cheap.
Well, here's my question for you, Adam, in that regard. And then I want to move on to the next topic because we could spend a lot of time on this. We got a lot of ground to cover tonight. But you have made the argument in multiple venues that somebody in the throes of addiction does not have the capacity to make any kinds of decisions whatsoever. And so I guess I have a hard time understanding how, first of all, you referenced Camilla Sword. She didn't have any fentanyl in her system at the time of her death. So to say that she was addicted to fentanyl but still using hydromorphone, the coroner found that the drugs that were most likely contributing her death were cocaine and MDA. So there's that piece. But if you view drug users as being so unreliable that they can't make decisions about whether or not they want to access treatment, how can you rely on their anecdotal stories when they're so incompetent?
Well, because the people who I primarily interview about this are people who are in recovery, whether that be people in recent recovery in London, Ontario, or youth who are in recovery in BC. Now, I never said that Camilla graduated onto fentanyl, but her friends did. And so in the article that I wrote about her, you have two friends who went down that path, who began on hydromorphone, got into fentanyl, and then went into recovery. So that's quite concerning. Now, as for the youth who I've interviewed beyond that, these are either youth who experiment with hydromorphone and then got off of it, or who talk about how their friends became addicted, even though they themselves did not use this drug.
How did they get into recovery without being diagnosed with opioid use disorder?
Those ones got diagnosed, but I'm saying that not just because the people who I interviewed were lucky enough to be diagnosed with opioid use disorder and were lucky enough to receive treatment, doesn't mean that everyone lucks out that way.
Shouldn't we see a spike in those numbers? Like, if the people that you're speaking to are the ones who are saying, I was in recovery, I was diagnosed with opioid use disorder, shouldn't we see a spike in those numbers of diagnosed opioid use disorders?
Well, once again, we're talking about a small number of cases. And one of the consistent themes that I heard when speaking with youth in BC is that there was a lack of support for fellow peers who became addicted to opioids, right? So they felt frustrated because they felt as if their peers were accessing dillies, getting addicted to dillies, and then basically left by themselves to get better, which I think that we can all agree is a tragic thing. I mean, Guy, you believe in making recovery accessible. So would this not concern you?
Well, recovery is BC is doing. One thing that I never hear you reporting on is BC's recovery services. There's over 3,600 recovery beds in BC. We also have launched the Road to Recovery at St. Paul's Hospital, where people could just walk in there to the RAC clinic and get diagnosed, see an addictions doctor, get into detox. I mean, there's a lot. We also have the recovery community centers, the VCH Junction recovery community centers. I mean, BC is probably, I would say, right on par. It might even have absolutely more beds, although Alberta calls them spaces, which is confusing to me, but we call them beds here. And the public funded beds we have are 3,600 beds. And I mean, but you never talk about this, but BC also does. I think he just seems so hyper focused on the safer supply stuff. Though, you know, I know that posted tweet that I screenshotted from you, you know, whenever you made it, was you now talking about it was diversion. But however, when you did say it, I will give you this, that you did respond to that tweet by even saying you were emotionally charged because you got off the phone with a youth. But however, it just seems, honestly, Adam, your reporting on it is so hyper focused on one solution. Sure, has diversion happened since 1990? Hell yeah. I mean, I could listen. I was the guy that was in the downtown east side. If I wanted hydromorphone, I can access it. How come? And also, too, when you're talking about the drop in prices, it's only focused on hydromorphone. I'd like to tell everybody that all pills have dropped on the market as well. And I believe what's happened, too, is there's a few factors here. But one is that fentanyl is so dirt cheap on the street that it did bring down prices. I mean, what I was paying for, you know, $25 worth of heroin, it's basically $10 today with the fentanyl that's on the street that people can access. And so, you know, and then also too, I mean, listen, like organized crime is very effective and efficient at pumping out drugs. They've just done it for decades. And that's just because there's no regulation around them.
Well, I mean, going back to your earlier point about diversion having always been a thing, no one who is concerned about safer supply diversion is denying that diversion is a decades-old phenomenon. We all accept that diversion has happened forever. What matters here is the scale of diversion, which we argue is unprecedented. If you want to make a comparison, imagine if there was a government which instituted a new policy which led to a huge amount of financial fraud. And then you say, well, actually, this policy seems concerning because it's leading to a lot of financial fraud. And then imagine if the government and its allies responded by saying, well, financial fraud has always been a thing. Well, obviously, you would say you're missing the point. The point here is the scale, right? Now, when it comes to the drop in drug prices, what is concerning here is that the scale of this drop is really significant in a way that it doesn't seem to be for other pills. So we're looking at a 95% drop. So whereas an 8 milligram hydromorphone pill used to sell for about $20, now it's selling for about 50 cents to $1 if you buy directly from a safer supply patient, and then they will resell it to drug dealers who would sell it for $3, usually in bulk, and then sometimes they'll be shipped across the country where street level dealers and other communities where safer supply is not available will sell it to $5 to $10. Now, what's interesting here is that there's this clear correlation between the price of hydromorphone and proximity to safer supply. This is actually something that was recognized by the London police recently when they came out, finally, after I pressured them for months, about the fact that hydromorphone seizures increased 3,000% after safer supply became widely accessible in 2020. So they said that they felt very confident about the fact that safer supply was related to the drug price drops because they saw that, you know, in London, you could maybe get an 8 milligram dilly for like, you know, $2, whereas in surrounding cities, they're about $15 to $20. And this is something that I've been hearing from addiction physicians as well all across the country. If you're right by a safer supply program, you can get it for $1. If you're farther away, it gets more expensive. And that's pretty telling.
But that's like that with any narcotic, any unregulated drug on the street. If you buy cocaine down in downtown East Side and go to Invermere and sell it, guess what? The price jumps. And the reason is because of how much drugs are in a specific area. And when you go into rural communities, those drugs aren't available to the extent. But that's nothing new though. And also too. But like I said, you can buy morphine is cheaper now. Percocets are cheaper. Tylenol 3s are cheaper. Methadone is a restricted drug that needs to be consumed in front of a pharmacist. And how come I can get that? If I wanted methadone, I could go buy it on the street. I mean, you've never been able to not buy drugs. If people want them, they'll get them, and they're all available. And they've always been available. And to your point with the safer supply as being the thing that's flooding the streets. Well, look at the pharmacy in Ontario that lost 245,000 hydromorphone pills. I mean, when you actually think about that, that's not something that's brand new. This is something that's been going on for a long time. And guess what? These are all products that happen in a manipulation of a market that's controlled, unregulated, unrestricted. And guess what? This is what they do. Guess what? If the drugs aren't available, they'll make them available. That's what organized crime does. And one thing that I look at is that, the focus here is that people use drugs, do struggle with addiction, but there's so many people that don't. And in my thing, I guess, when I look at a lot of people, is they seem to be more concerned about addiction. I'm more concerned about people dying. I can work with people who struggle with addiction. I can't work with people who are dying, or if somebody, and for me, I mean, it's not rocket science, but in any person or any family member that I've talked to that have lost their loved one, they wish they had access to a safer alternative other than that supply. And in BC too, I mean, heck, we don't have too many people on safer supply. It's about 4,300 people. And the truth is as well is that they're not staying on it for years either. There's extreme barriers and challenges and protocols in place as well for them. And, sometimes they do it for a couple months and move on. But I know so many people that have stabilized on it and are getting it and are getting OAT and their lives are better. But I think where the issues is that we have here is that this political rhetoric is that, everybody needs to not do drugs. And I wish nobody had to use drugs. But the truth is that that's not a real world solution for people to become abstinent. That takes like a long time. Like it took me 31 years to figure it out. And sadly, in today's day and age, people aren't going to survive like 3-4 years because that toxic drug supply is going to kill them. So we just have to do a better job at addressing the toxicity in the supply, because that is the gun.
Well, I mean, I want to address something that you mentioned earlier about how that there are only 4,500 approximately safer supply patients in BC. That point is often brought up to minimize the risks of safer supply diversion. People say, well, it's such a small patient population, how much damage could they actually do? And what's often omitted in this conversation is the amount of hydromorphone which is dispensed to this small population. So a safer supply patient in BC will receive usually 14 8-milligram hydromorphone pills every single day. So, we're looking at about 108 milligrams. And then in Ontario, they receive about 30 to 40. So let's say about 240 milligrams to 320 milligrams every single day. Now, for comparison, someone who's being treated for acute pain, for example, you just came out of surgery, you'll receive about 2 milligrams every 4 to 6 hours. So let's say 12 milligrams a day, right? So you're receiving about like 9 times more hydromorphone in BC than a pain patient who's in acute pain. In Ontario, you're receiving about 20 times. Now for chronic pain patients, if you have severe arthritis, usually they give about 12 milligrams a day. If you're a late stage cancer patient, you're getting maybe about 100 milligrams a day, but those patients are not going to be diverting their safer supply because they're near death. Sorry, they're hydromorphone because they're near death and they need that to actually manage their pain. So once again, like one safer supply patient is receiving 20 times more hydromorphone in Ontario than the average chronic pain or acute pain patient. Now, what was interesting is that Fiona Wilson, who is the deputy chief of the BC Association of Chiefs of Police, said in Parliament recently, I think back in April, I believe, that half of the hydromorphone recently seized in BC can be attributed to safer supply. Half. Now, I looked, like, the most recent data that I could find on the total number of hydromorphone patients in BC came from about 2018, 2019. It was the BC Atlas of Drugs. So they put the total patient population at around 80,000. That might have changed since then. But okay, so you have 80,000, non-safe supply hydromorphone patients and about 4,500 safe supply patients. So safe supply patients are about 5% of the total hydromorphone patient pool, yet they account for half of the all diverted safe hydromorphone. So that would suggest, when you crunch the numbers, that the average safer supply patient is diverting approximately 19 times more hydromorphone into the black market than the average pain patient, which is concerning.
I think there's two pieces. I want to just hop in real quick here because there's a point of clarification that needs to be made. That same chiefs of police also said diversion has been a problem for time immemorial, and that she wasn't seeing the diversion of hydromorphone or Dilaudid causing problems on the streets anywhere near the same scale as the illicit market was. I think one of the other things that is also important to highlight is when we talk about these seizure numbers, the cops aren't testing every pill. They're not testing every pill to determine what pills have they're actually pharmaceutical diverted hydromorphone or Dilaudid. They're saying we collected or we captured 300,000 pills, and boy, do they sure look like it. But there is a very real problem. I mean, CTV just ran a story not very long ago where they talked to somebody who was they gave her the name Cassie, and she talked about the fact that she is a daily user, and the only time that she's ever overdosed, and I want to read right from the story so that I get it right, the only time that she's ever overdosed has been when the pills that she took contained other opiates and MDMA. So if there are pills out there that are good enough to fool the people who use them all the time, and the police aren't testing every individual pill, the police can stand up and say, hey, we seized 300,000 pills, but of that 300,000, how many of them were actually pharmaceutically generated pills that actually contain hydromorphone? We don't have the answer for that. Anyways, Guy, you had something that you wanted to say there.
Well, I mean, like I said, I mean, safer supply to me is a part of the toolkit that we're going to use and need to support people. If it doesn't work for everybody, then find something. We need better solutions for that as well. And guess what? Like, heroin programs work very successful, Switzerland, Denmark. But the reality is in our world today, I see what's killing people. It's toxic drugs. That's what people are using and buying. And like I said, that's what we have to address.
So let's talk a little bit about safe supply, because the schools of thought. I mean, I don't want to. I'm going to go to you first, Adam, to sort of explain your position on it, because in varying different sources, you've said some pretty extreme things about safe supply. At the beginning of this conversation, you said yourself that you can see a place for it, given certain measures taken to make sure that it's not being diverted. So I want to talk about the thoughts on safer supply as a tool to address the opioid crisis, to address the toxic supply crisis, and to prevent people from dying. So, Adam, it's all yours.
Sure. I mean, look, I think that a responsible model of safer supply would be one where supervised consumption is mandated. That would immediately cut out over 90% of diversion. And one where there's a clear recovery-oriented goal. Because if you just give people unlimited access to a quote-unquote safer supply, they have very little incentive to seek recovery. And that's something that I'm seeing a lot in many of my interviewees and some of the data that I've been reviewing, that safer supply has been dissuading people from accessing OAT. So if you say to someone, okay, we're going to give you a safer supply, it's going to last for a few weeks to a few months to help you get titrated onto oats, and we'll even give you your drug of choice. We'll give you, say, fentanyl or sufentanil in a tightly supervised environment. I can get on board with that, because that would resemble injectable opioid agonist therapy, which was what Guy was mentioning earlier, wherein stronger, shorter acting opioids were provided to heavily addicted drug users in a supervised setting in conjunction with wraparound supports. We have evidence for that. What we don't have evidence for is our current model, where we essentially hand over someone a bottle of pills with no real way to verify whether or not they're actually taking it, and say, here, do your best. Hope you get better eventually. Don't worry, we're going to give you these drugs indefinitely. That's irresponsible.
That doesn't happen, though. I mean, there is wraparound services. You have a prescriber. It's, I always say this: it's not public interest to know patient and doctor confidentiality. I mean, these things, there's protocols that are in place. I mean, there is wraparound services. I help people get these wraparound services consistently and constantly. I mean, there is a wealth of support for people who have access to any substance through medical practitioners. This is the harm reduction approach. Like, if you think too, as well, as that, I wouldn't have a life today without that approach. And the other reality is that we don't even have enough data as what's successful for people completing treatment and recovery. Listen, I've seen many people complete treatment, and then I see many people go back to using the substances. And I will tell you this too, as well, is that safer supply isn't a barrier for accessing people to get treatment. People go when they have the desire to stop using. And you know what? I always had as much access to substances my whole, never have to quit if I didn't want to. It was when I wanted to is when I did. And there's a lot of people that go through different motions when you're struggling with addiction, that you do feel like, this is the day I want to take a break. And the unfortunate thing is that it's not somebody walks through a front door of a treatment facility and walks out the back. And many people who have died of a drug overdose, the majority of them, have sadly tried treatment and recovery, but yet the sole focus is that everybody's trying to blame harm reduction measures or safer supply. To me, it's the same thing as us saying, then we should start blaming recovery services then for not keeping people sober, because, the truth is that, you can't point fingers at one. You're going to have other ones pointing back. And the reality is, in our world today, is that there's a lot more to what people say about getting off drugs, that their life will get better. I got off drugs. My life didn't get better. It got better in the sense that maybe I had a bed and a place to stay. But what didn't get better was a lot of other unaddressed societal issues as well. Homelessness. There's a big things that are being missed here. And just telling people to get off drugs is, kind of a fantasy if we're not going to go all in and do everything. And that would include a harm reduction safety net underneath it, because I just can't send people to treatment and then them leave and not have access to those services. That's like handing somebody a gun after they leave.
I mean, look, I would be much more supportive of safer supply if I believe that it actually shepherded people into recovery, but that doesn't seem to be the case. So what I'm hearing from addiction physicians across Canada is that there has been a significant decrease in OAT services over the past year or two, because patients are abandoning OAT in favor of safer supply, because safer supply is easier. In fact, Dr. Sharon Koivu in London, Ontario, recently conducted a chart review of 200 patients between January and June of 2023. And not only did she find that 1/3 of patients who were not on safer supply self-reported accessing diverted safer supply hydromorphone, there was also a strong association between being on safer supply and not getting on OAT. So 50% of patients who were not on OAT and not on safer supply would initiate OAT upon being discharged from the hospital that she worked at, where she provides addiction services. Only 5% of safer supply patients who were discharged from hospital would engage in OAT. So that seems to validate these anecdotes that I'm hearing from physicians. On top of that, Dr. Bonnie Henry's report, where she basically engaged with addiction physicians and healthcare providers all across BC for months, and then she published that back in January and February, her findings. One of the most interesting findings there was how physicians across the province felt moral distress, because they felt like by providing safer supply, they were actually freezing the recovery journey of their patients. The patients were getting better. They were just using their hydros or selling their hydros to get their drug of choice, and not getting better, not getting on OAT. And I think that we can all agree that that's a problem.
Was Dr. Koivu's research peer research, or was it just doctor research with her 200 patients?
I'm not sure where it is right now. I know that they were in the process of getting it peer reviewed the last time I checked in on this.
So so not peer reviewed, those numbers that you have at that time. I want to just point out though that it kind of seemed like you ripped right past Guy's points about people use drugs not solely because they're physiologically addicted to drugs. They use drugs because there's things in life that suck. I'm paraphrasing a little bit, Guy. Please forgive me. And if you don't deal with the things in life that suck, then they're not going to be able to recover. That's just the bottom line. And so if you're not in a place as a society where you're willing to say to somebody who is at a point where they're able to ask for help, if you're not willing to say as a society, hey, great, we're going to meet you all the way. We're going to get you housing. We're going to get you don't have to worry about the food. You don't have to worry about the bills. We're going to take care of all of those external stressors. And we're going to not force you to deal with the things that pushed you to use drugs, or predisposed you, probably is a better word, to use drugs in the first place until you've actually dealt with them. Like, to me, speaking for myself, when we talk about safe supply, it serves two goals. One of those goals is to, as Guy has said several times now, keep people alive, because the toxic supply is what's killing them. Again, the CTV story with Cassidy, where she was very clear the only time she overdosed was when she was taking drugs that she thought was one thing and it turned out to be another thing, because that's what organized crime does. But the other piece is, once somebody's at a place where they say, you know what, okay, maybe I'll give this a try. Maybe I'd like to take a break, whatever the case may be. Maybe I'd like to deal with all of the repressed childhood trauma, or the sexual trauma, or the physical injuries, or the. But I'd like to do that and not be in it entirely. Can I maybe have a little something to take the edge off while I do that? And that, to me, is another place where safer supply, or prescribed safer supply, plays a big role. So I'm curious what your thoughts are. Those, do you perceive those to be legitimate, or do you perceive those to be illegitimate?
I think that if there is a benefit for safer supply, it's its capacity to connect people to additional supports. There was a study that came out in late 2022, which suggested that enrollment in the safer supply program was associated with positive outcomes. The problem with that study is that they made no effort to discern whether these positive effects came from the hydromorphone itself or from all of the additional supports.
Well, of course, it's not going to come from the hydromorphone itself.
No, but if your argument is that using safe drugs is going to save lives, then the hydromorphone itself should be sufficient to show that some positive effect, and you should have some sort of research, measuring the effect of just providing hydromorphone without the confounding variable of other supports.
So, I mean, I think it would be pretty easy. How many of the people who were on the hydromorphone, who were using the program, didn't die of a toxic supply overdose?
But the problem here, like whenever you have a study, whenever you have an intervention, you have to filter out any confounding variables, right? So if you go and you provide someone with hydromorphone as well as additional supports, and then you see positive outcomes, you have to find a way to filter out all of those other effects. It's like, for example, taking an obese man and giving him a free slice of cake every week, plus a personal trainer, plus a therapist to talk about why he eats. And when you see that the overall program works, conclude, well, we should give people a free slice of cake every week, right? Now, the way that Safer Supply is developing in Ontario is not the way that I would imagine you guys would want this to develop. So what we're seeing in Ontario, and this is a more recent development over the past year or so, is that doctors have begun to clue into the fact that Safer Supply can make a lot of money. And so now what you're seeing is pharmacies which dispense Safer Supply, which have terminals in them where a drug user can go in, get their Safer Supply prescription in like under 5 minutes at the terminal, and then immediately fill it out. There's almost no engagement with the healthcare system. There's almost no psychosocial support here. You are just going in, a doctor will remotely prescribe you Safer Supply, you'll get your pills, you leave, that's it. That's irresponsible. And this mirrors some of the irresponsible forms of OAT that we saw 2 decades ago, where you had methadone providers more or less doing the same thing. Telemedicine has a lot of virtues in many ways, but unfortunately, we're seeing telemedicine being used in the safer supply system in a way that is irresponsible and is minimizing the level of the engagement that people have with their physicians and the level of additional support that they receive.
I'm curious. So is that the scam part? Because you've referred to safer supply as a scam. And this kind of gets into the next piece that I wanted to spend some time on in regards to the language, how we address these things. I mean, you gentlemen have both been in sort of an ongoing Twitter tete-a-tete. Is there responsibility for people who are having this conversation to make sure that they're using responsible, non-inflammatory rhetoric, or is the situation so dire that anything goes?
Guy, do you want to answer that?
For me, I think there's a lot of factors that go into this. I think there's a lot of political motivation on certain groups. I think the stories on safer supply throughout the media has definitely created a lot more awareness on safer supply, that there is a market out there. I think there's a lot of factors that go into this thing, but I try to keep everything out of the personal realm and not personally attack anybody. I try to look at the data and break down the misinformation that's involved through it. And guess what? I mean, I think it infuriates some people that they get upset, and I get a lot of responses from a lot of people, but just the other day in Montreal, where some a politician is talking about the legalization of crack, and it's incorrect. And so I think what this does is this fuels a rolling train. And I've witnessed the same things before with the HIV/AIDS and the overdose crisis in the 90s, when it was a political football, and that's collecting votes off the lives of people struggling. And for me, that's the part that we haven't learned from our past mistakes. And guess what happens is a lot of people died because of it. And I think for me, when I see people, I've seen a lot of death in my life, a lot more than a lot of people will ever see. And that's not something that is easy to get over. And it's very emotional for me. And there's a lot of people, sadly, that I still see this happening with today. And so I'm very passionate about it. I'm going to keep fighting. And I'm going to, always try to present the facts and the truth and the data that support it, instead of anecdotes. And, that's just what I do.
I mean, I think that some of my followers would disagree with how you've characterized your tweets. So you had mentioned that media coverage of safer supply has in some way advertised it and has led to this diversion crisis, which I would disagree with. And for context, for people who are listening who haven't been following our Twitter accounts, I wrote an article about a month ago about a CAMH study that basically showed that the rate of youth self-reporting accessing, or rather using, pharmaceutical opioids for non-medical purposes jumped by 71% between 2021 and 2023. The survey that provides this data is done every 2 years, so we don't have the 2022 numbers, right? And that same report found that there was a 40% increase in youth who said that pharmaceutical opioids were easy to get during those 2 years. Now, that coincides with the rise of safer supply. As this data was gathered towards the middle of 2021, for the 2021 survey, we can exclude the first year of the pandemic as motivating this effect. And then, I mean, Guy, you basically said that I was the reason for this spike, that I, through my reporting, had caused a 70% increase in pharmaceutical opioid use. And look, I know a lot of people read the National Post, but I don't think that teenagers are reading the National Post and saying, I'm going to go buy Dilly's now. Now, the important thing here to note is that the report looked at changes in opioid use between 2021 and 2023. The 2023 survey data was gathered between January and June of 2023. My report came out in early May 2023, which would imply that about 75% of the survey's were already gathered at that time.
Okay,
So,
I'm gonna jump in for a quick sec here, Adam, because I think we're getting away from the greater point here.
Yeah.
The question and the point that I'm trying to ask is: should people who are commentating on the opioid crisis be responsible for the rhetoric that they're using? That's it.
Yeah, I mean, yes.
So then the follow up is: why did you call Safer Supply a scam?
Because in many respects it is a scam. I mean, look, pharmacies can make a ton of money off Safe Supply. So a number of physicians have crunched the numbers. If you have 100 Safer Supply patients and you're getting your daily dispensing fee every single day, you can make over $1 million from that. Versus someone who is stable, who is coming into the pharmacy once a week or once a month, if they're on Sublocade, there's a lot less money there. So,
but somebody who's on Sublocade, as we talked earlier about the continuum of addiction, somebody who's on Sublocade is going to be in a very different place on that continuum than somebody that society has said, hey, you know what? We think you're worth it. And we're going to try to keep you alive. But the greater question that I have is, like, you've said at some points in this conversation that you believe that there is a place for Safer Supply. When you make blanket statements like Safer Supply is a scam, or I believe Safer Supply is a scam, that to me is a broadly negative statement that paints the entire thing. And if we're going to have a nuanced conversation about these issues, especially when presumably the goal is keeping people alive, don't we have a responsibility to not use that kind of language?
well, I believe that the current model of Safer Supply is a scam. I believe that when critics of Safer Supply have tried to raise concerns in a nuanced way, that's often been missed. I mean, let's look at those addiction doctors who wrote several public letters last autumn to Minister Sachs about Safer Supply. They advocated for reform, and if not reform, abolition. And many of the reforms that they advocated for were quite reasonable, one that we should all be able to agree with. For example, replacing tablet hydromorphone with liquid hydromorphone, because when you crush tablets that are meant to be that are meant to be used orally, and then you inject them, that leads to infections, right? So they had a lot of thoughtful recommendations for reform, and yet they were smeared. You know, Guy, when we went for lunch back in October, you asked me, why didn't I speak more openly about my desire for a more responsible model of Safer Supply? And I included that in my long report for the Macdonald-Laurier Institute about Safer Supply fentanyl. There was an entire section at the end that advocated for the very things that I just described, you know, a recovery-oriented, supervised model of Safer Supply. And yet no one seemed to notice that. You continue to blast me on Twitter nonetheless.
Well, Adam,
it was a 10,000 page or 10,000 word article. It was a long article. I mean, listen, like, you know, honestly, when we also had lunch too, you also reminded me as well, if we're going to go on this topic, that you were saying you're reporting Jimmy to, you know, a table inside for supply, but yet at the same time, I told you, no, there's always evaluations of programs. But yet when I say that, hey, the reporting that not only you've done, but which is also your reporting on Safer Supply, has not just gone through the National Post. It's also gone through politicians, clips, posts, not just on social media, Twitter, but on Instagram and other platforms that kids can access or other people can access. And so it did bring a tremendous amount of awareness. And even when I said, hey, BC's numbers are going down, you know, there's slight decrease, and, you know, maybe it is a credit to all the reporting that people are actually noticing that there is hydromorphone on the street and that they can use it as an alternative instead of accessing the fentanyl. And my response to that was still, hey, just listen, anything bought off the street, please get it checked, because that's how dangerous it is. I don't care if it's in a prescription bottle or in a baggie. But like, I mean, you know, to me, it's just a constant targeting of like getting rid of this program. And if you're going to do an article where you're going to say, hey, listen, I support Safer Supply, it just needs to be done better, then do it. But don't do it in some massive component. Do it in something that actually says something. And I don't know if you can do that or would do that. But I mean, listen, the one thing that I constantly support is helping people. And I understand that that's a long journey. I don't believe that safer supply hinders people from going into recovery and treatment. And if we don't actually really keep people working with people while they are struggling, then if we take away these solutions to benefit people, then that'll be the only game in town, which will be the unregulated drug supply. And we will see the deaths go way higher. And my concern is also, too, with Pierre Poilievre coming out and saying that, calling supervised consumption sites drug dens and, crime, crack, and chaos, and just this rolling rhetoric that he'll defund them all. I mean, this could be a really dark time moving forward for people who are struggling. And that's just something that I can't keep quiet about. And I get a lot of flack, a lot of DMs, emails, hits on my website from people, telling me to go die, telling me that I'm killing people, but the truth is that for the people that do know me, I'm on those front lines helping people, getting them into treatment. It's just one of those things that takes a lot of time. And for people, I'm the guy that builds relationships with people, and without harm reduction, you ain't building a relationship with people who are using alone in a back alley. That's where we all have to just come on board and say, hey, listen, we'll support treatment and recovery. I support that wholeheartedly. If my best thing is to get everybody that wants to get off drugs to never use drugs again, but also knowing that if we don't have all those systems of supports from harm reduction services in the landscape, then people will just go into treatment or go into prison, walk out, use again, die. And for me, I've seen that happen my whole life. And that's not something that we can keep doing in our society, because the drugs are now 10 times worse.
So I guess the question is, again, and then I want to move on to because I said we'd max out at 90 minutes. We're coming up to only 15 minutes away from that, and I want to talk about forced treatment. But again, the question is, for people who are holding themselves up in front of microphones, should they be responsible in how they're choosing their words? And again, I'm going to go back to the scam thing, Adam, because you've said that you view Safe Supply in its current iteration as a scam, but that's not what you said on the program that I'm referring to. You simply said, I believe that Safe Supply is a scam. And when people who are listening to those programs, especially given that you're appearing on a lot of programs that are followed by people who have either been traumatized by their life and they've used, or people who have been traumatized by the fact that someone that they love is sorting their way through these processes, or they've lost someone they've loved to these processes. When somebody steps up and says, the whole thing's a scam, that takes that, for that audience, that takes that option in many ways off the table. And so I'm just wondering if you're willing to clarify. You have issues with some of the models of Safe Supply that are being utilized across the country, but you do, or if you do believe that there's a place for it.
I think that there's a place for it. And if it's in a radically different model, and we see that already in Alberta with their narcotic transition services, where they offer liquid hydromorphone to people who are severely addicted in the IOT system that was pioneered in Switzerland that Guy referenced earlier. And I think that kind of model would work. At the same time, you guys mentioned earlier how not everyone has the time to read a 10,000 word article on drug policy. Similarly, people often don't have time to hear about all of the nuances of this issue. So I often have to condense what I talk about. I don't always get to have a 90-minute conversation with harm reduction advocates about safer supply. And my main goal right now is to impress upon people the fact that diversion is occurring. It's occurring at an unprecedented rate. It seems to be dissuading people from accessing recovery-oriented services. It seems to be associated with horrendous infections, which we haven't talked about through this segment, but that's a whole different other thing that is underappreciated. And that there seems to be a significant element of profiteering here, which raises questions about whether or not we're pursuing the optimal approaches for treating people. So,
and I think there's a difference between saying that. I mean, if we're talking about a 6-second soundbite, I can say, look, I believe in safe supply. I believe safe supply can save lives, but the systems that we're using definitely could be a whole lot better. I just did what you did on that podcast in the same amount of time, and I didn't say, it's a scam, is what I'm trying to get at.
Also, just I've had so many life-threatening infections because of safer supply. It was because of the substances that are on the street. You want to talk about a person that's had 5 osteomyelitis bone infections, like 4 in my left leg, 1 in my back, where I had to relearn how to walk again, rhabdomyolysis, septicemia. I mean, if you want to talk about obnoxious drugs that are on the street, the reality is that for people who use drugs too, as well as the time consuming when you're using them outside, you don't have time, since you just put them in a syringe and blast them. That's why it's important to have drug user education on people to understand that if you are using these substances, to filter your drugs. But the reality is that these chronic infections, I see them all the time, and the drug supply that's on the street, I mean, it's nasty sores on people now. I mean, it's really, really tragic.
Well, I mean, do you guys mind if we do a few minutes on the infection piece? Because I think that's something that everyone from every side can at least agree upon is a big problem that we should try to fix.
Well, I don't want to do a few minutes on it. I think we can just say we should be doing everything we can to prevent drug-related infections.
Yeah.
100%.
Again, we can be quick.
Okay, so just say this quickly. Okay, if you crush and inject a pill that is designed for oral use, the excipients of the pill,
any pill. And I'm going to stop you here because I actually have the experience and I have the expertise here. As a clinician, if you are not following safe protocols when injecting anything, anywhere, you can get infection. It can range from something as simple as putting your thumb on an open wound, all the way to, yes, you're putting more and more toxic things. There are some things that are more toxic. There are some things that are more irritative, for sure. And we should be doing everything that we can. But to try to say that we're seeing an increase in infections because of specific substances and not because of lack of clean needles, lack of safe places to use them, lack of supervision, lack of places that people can go to get treatment when they're dealing with infections, that's just not a rabbit hole that I want to go down when I have 12 minutes left and I want to talk about the forced recovery piece. So, yes, I think we can all agree, and I could even include it in the earlier clause, we should be doing everything that we can to prevent infection secondary to drug use.
Dr. Sharon Koivu has peer-reviewed research showing that hydromorph content is particularly dangerous.
It does, but again, Adam, the point that I'm making is, going back to Cassidy, people are buying pills that they believe are safe supply that are absolutely not safe supply. Black market, organized crime is going, hey, if we tell these kids it's safe supply, they'll feel better maybe, and they'll buy more. So I'm going to sell them this concoction that I made in Doug's basement over here, and they'll inject it, and I don't care because I made my money. And that's the bottom line. So I don't want to, I no way, because let me tell you, I've seen firsthand the types of infections and wounds that can come from all of the other things. But I don't want to spend the time on that when I now have 11 minutes left to talk about forced recovery. So that being said, the province of Alberta has said, and we're likely to see the framework coming out in the next couple of months, that they're going to be pursuing forced recovery. Forced recovery being the notion that if somebody is using drugs to an unacceptable level, that they somehow lack capacity or competency, and they should be, in effect, incarcerated, taken off the street. Adam, this is something that you've advocated for. I can play a quick clip here where you recently talked about competency and involuntary treatment.
Would agree. Most Canadians can see that if someone is severely addicted and tweaking out on meth, or constantly nodding off on fentanyl in the streets, that they don't really have a free choice over themselves. They don't really have any capacity to understand what's best for them. But the problem goes back to the thing that I mentioned earlier, where a lot of addiction policymaking is driven by these drug user activists. And so for them, if you suggest that drug users may not have the ability to understand what's best for them. They view that as being deeply offensive and paternalistic, and they say that you're the bad guy. They say that you're evil, you're stigmatizing them. They'll do anything to minimize the harms of addiction when everyone else can see the obvious, which is that someone who is severely addicted needs to be thrown into treatment regardless of whether they want to. And sure, involuntary treatment is less likely to succeed than voluntary treatment. I don't think that's shocking to anyone, right?
Yeah.
But it's better to put someone in involuntary treatment, even if it's less successful, rather than to leave them on the street to harm themselves and others. Like, yes, it'll take multiple times, multiple efforts, but we need to make that investment rather than abandon people to death.
So I wanted to play the biggest chunk of the clip as I possibly could without spending the whole show broadcasting someone else's podcast. But the argument that you make in that clip, and I want to know if you stand by, is that if I disagree with someone's life choices and I believe that they're making choices that are not good for them, they are not competent. They lack capacity. And before you answer this question, I want to be really, really clear. When we're talking about competency, there's some really important things to highlight. Competency is not making good decisions. Making good decisions is not indicative of competency. It's the ability to understand the decisions and the potential consequences. The definition that Alberta Health Services uses is it means that the person can understand the subject matter relating to and consequences of making decisions or giving consent and the consequences of not doing so. So if somebody understands, if I continue to use drugs, I could die, that is not indicative of them lacking competency or capacity. It's also critically important for me to point out to my audience that when we talk about removing somebody's right for self-determination, you're talking about violating a charter right. It's also critically important to point out that when we're talking about who can do capacity assessments, we're talking about an actual clinical procedure. We're talking about an actual way that clinicians are required. It's a step process that clinicians are required, and it's very limited as to who can do it. Physicians can do it. Psychologists can do it. And if they're appropriately trained, if they've received the specialized training, nurses, psychiatric nurses, social workers, occupational therapists. Me as a paramedic, I don't have the ability, nor do I quite frankly want it, to determine whether or not somebody has capacity or competency. It is a legal process and it's a clinical in-depth process. So, and again, this goes to the rhetoric piece. I quite frankly don't care what the majority of Canadians think when they're looking at somebody who's tweaking on methamphetamines or nodding off on opiates in regards to whether or not they have capacity or competency, because the vast majority of Canadians aren't physicians, psychologists, nurses, psychiatric nurses, social workers, or occupational therapists. So all of that being said, you have defended the idea of mandatory treatment, forced treatment, because feelings, I guess. What's your position on it now?
I still defend it. I compare it to forced treatment for someone who's going through a mental health breakdown. I mean, we routinely accept that is appropriate. I saw this in my own family. My own father was, put into treatment against his will because he was a harm to himself and others. And I think that we can accept that someone who is in severe addiction does not have the full ability to evaluate their own decisions. And that when you talk to people who are in recovery, they routinely admit that. They routinely admit that in the throes of addiction, they didn't know what was best for them. I think the kind of person who abandons their family, who lives in a tent in the cold, in the rain, just to get their next fix of fentanyl, is maybe not in their right mind. And I think that it is compassionate to acknowledge the fact that someone is not fully in control of themselves, because the alternative is to use this kind of moralizing language, which I know that you guys are against, to say that people are making these free choices and therefore are responsible for the harms that they inflict on others. And I think that we can all accept the fact that they are not.
I gotta get to Guy in a sec because I really want to hear his take on this. But again, I gotta reiterate, you're talking about I have feelings about how people are making their choices. And again, you're looking at the competency and capacity piece as if it's something anyone using their own moral judgment can armchair quarterback, and not like we're talking about the revocation of a charter right, and not like there are existing clinical requirements for how to determine if somebody has competency and capacity, even if we don't like what they're doing. I also want to highlight, I'm sure Guy's going to get on this, but I also want to highlight that, you said people are living in tents to get their next fix of fentanyl. I think that's an incredibly disingenuous argument, because the reality is a lot of the time people are using to numb the pain of being on the streets, either because of economic reasons or psychological reasons or mental health reasons or a whole bunch of other things. But again, this is where I'm getting frustrated. I'll own that, because the rhetoric that you're using is incredibly emotional and it's incredibly compelling, but it's not based on current clinical practices. It's not based on a recognition of the importance of the charter. And the fact that your narrative, your stories, your editorials are used by politicians to justify policy decisions that will be, according to legal and constitutional experts, illegal revocations of people charters' rights. I'm just stunned, quite frankly, that you don't seem to have a grasp of the enormity of that. And I'll give you a chance to respond to it. But before I do, because we're coming up to the end of time, I want to give Guy a chance for his thoughts on the forced treatment.
I mean, I come from the Olympics of drug using, so struggled using substances for 31 years, and I had made the choice numerous times that when I felt like I needed a break, I went to treatment. Forcing people into treatment is not going to go anywhere. It's actually going to cause a tremendous amount of harm for people. And then, for people who do go into treatment and recovery, there has to be a desire there as well, for somebody to want to be off substances. But if desire isn't met also by equal opportunity in community, with a wealth of services after, then guess what? That desire gets hammered on the head because those opportunities don't exist. And to insinuate that I made a choice to be living in a tent, or I didn't choose to have, be homeless. I didn't choose to have mental health issues. I didn't choose to struggle with addiction. I didn't choose to, follow the path that I did. I didn't choose trauma. I didn't choose childhood abuse. I didn't choose foster care. Those were out of my control. And what they did do is that if you don't have those unaddressed societal issues, then guess what? People are living in tents is because they can't afford to live anywhere. There is no places for them. And it's not like they're sitting in a tent waiting for their next fix of drugs. They're sitting in a tent because they can't access housing and there's not enough support, but everybody wants them to get off drugs, but that's not going to change people's circumstances. And if you don't remove somebody from an area and give them something better to have after, than just telling people to get off drugs and go to treatment. Those are simple slogans that aren't going to work. And then telling somebody that you don't have the capacity to make a decision in your life because you're using these substances and you need to go to treatment. Also, at the same time, knowing that it's a chronic relapsing condition. People will die when they go back to the street. It will also fuel more people be driven in isolation, not reach out for support and help, and they'll die because of it. And my thing is to be kind and work with people through the times that they're using drugs, through the times that they're struggling. And I tell you, I got this person, name's Donna, in the downtown east side. It took me a couple years to finally get her housing. And I remember when I saw her, she was so happy. And her words were, "Guy, I have 99 problems, and who'd have thought getting housing would solve 90 of them. And now I can work on the other 9 that I'm dealing with." And to me, that really made a lot of sense, is that the stability in people's lives starts with that. And we have to do a better job because there is no housing right across Canada.
So in response, so first of all, I want to say it's not like you guys are treating this like there's mutually exclusive in terms of homelessness and addiction. Yes, there are some people who use drugs to deal with the fact that they live in tents. There are also people who live in tents because drugs destroy their lives. We're treating these two things as if they're in opposition, but they're very harmonious. Regarding the constitutionality of forced treatment, I mean, that hasn't really been adjudicated yet, and I think it should be adjudicated. And I think that given that we have a legal framework for forced institutionalization of people who are mentally ill, I think that there's a good chance that forced treatment.
But that legal framework can only be accessed by people who have the clinical ability. Again, this is my point. To say that, oh, you see someone nodding off, you see someone who's tweaking, they clearly can't make decisions. They need to be scooped up and put somewhere, which has, by the way, a 90% relapse rate and a 90% increase in death. So it's not like we're necessarily doing these folks a favor. But to say that because I don't like what I'm seeing, rather than say, hey, you know what? This person doesn't have all of the supports that they need. Let's maybe, instead of stigmatizing and saying that these people lack the ability to make decisions, instead of doing that, let's maybe build a safer supply network that doesn't have all of the things that you're concerned with. And while we're doing that, let's also build in the social supports so that these people will still be alive to be able to access the things. Because again, I go back to the statistics that I talked about at the beginning. Only 50% of people who are diagnosed with a substance use disorder get all the way off. 50% don't. And it seems like the focus that you're putting things on is, well, if we just force people enough, then they'll be okay.
Well, so I want to clarify that I'm not advocating for a system where some random member of the public can call in and say, oh, I saw that guy tweaking, force him into treatment. No, we both are on the same page when it comes to the need for a rigorous process with respect to whether someone's put into forced treatment or not. Now, in terms of the efficacy of forced treatment, I think that we saw that to a certain degree with the Portuguese model decriminalization, which didn't decriminalize drugs in the way that many people believe. Instead, you had a parallel system that was outside of the criminal justice system that used coercive measures like fines to pressure people into treatment. That worked. So why don't we do a slightly...
Well, I would argue that it also doesn't get to minus 40 in Portugal all that often, but I'm not particularly clear on their climatology.
And then when it comes to, you advocating for giving people better treatment options, I agree with that. I think we can all agree that we need better social support systems. At the same time, that can coexist with the need for forced treatment for people who are particularly incapacitated due to severe addiction. And I think that that's the compassionate approach. If someone is so enmeshed with an addiction that they essentially have no capacity of pulling themselves out, we need to help them we need to pull them out for them. Otherwise, we just leave them to kill themselves.
I think you're still glossing right over you're focusing on the addiction as if it's purely the disease and not a symptom. And I think that's where so much of what perceives to me to be a disconnect is for you, because you're not looking at let's just solve the addiction. We'll solve the problems. The addiction is a symptom of whatever led them to the addiction. And if you can't view it that way, then you're just treating the infection from the needle use by slapping a Band-Aid on it. I don't see it anymore, so it's fine. The reality is, as we all agreed at the beginning, there are certain things that predispose people to addiction. And until they can deal with those things, it's going to be very, very difficult, if not impossible, for many people to be able to extricate themselves from addiction.
I mean, I think that, of course, any kind of forced treatment needs to be paired with additional supports to ensure that people have the housing support, social support, psychological support to get back on their feet. I don't think that we should just throw people into forced addiction and not address why they use drugs in the first place. I mean, that's just stupid.
That's exactly what the province of Alberta is.
But that's exactly what we do. You can't go through. I mean, I worked in the private treatment industry. There's no trauma therapist in there as well to deal with those. And you're not going to tackle a lifetime of trauma in such a short time frame. And so what the sole focus has always been with these treatment facilities, there's the, getting off the drugs. And I will say this, and I say this quite often, is that depending on the circumstances in people's lives, like if you take a CEO from a company and they've had, a great career, family, job, all these other factors in life, they had everything you could ever want. They tank their life, struggle with addiction, go into, lose their family, their children, then get into treatment. Families, they're supporting them through it all. Then he finishes treatment, and then everybody, oh, this is fantastic. We love it. We, let's give him all these opportunities again because he's so successful. And then hence a person struggling in poverty, downtown East Side or wherever, who's never had those opportunities, never knew how to, do a resume, get a credit line, bank cards, driver's license, access to housing, get employment. It is much harder for them to move forward and have the same success. And there's not equal opportunity provided to those people as well. And so it's really, for us, I think, the thing is that we just hit the low hanging fruit, the people who are struggling on the streets. And it's such a challenge for them to move forward with their lives because we don't address those unaddressed societal issues. And another thing too, when we're not just shaming people for their struggles, we're also shaming people for how they address their struggles by what they're doing today. And so a lot of it, I've heard, I've never heard somebody that struggled in addiction that hadn't struggled with some form of abuse. And that to me is the real challenging thing for people to get over. And you can't force people to deal with trauma. Trauma is one of those things that takes a lot of time. And it took me a long time to be able to look at it because it's just too painful. And I needed a lot of help for that. And once I'd gotten help with trauma and been diagnosed with ADHD and other learning challenges that I had throughout my life, it started to make sense of why I gravitated to the substances so much. And that's what really got me to a place where I could eventually treat my own addictions that I was dealing with. And that's what the credit is. But if, without all of that in place, I'd be dead. I wouldn't have recovered without harm reduction. And I just wish people could understand that a little bit more, that this is a lot bigger than what we're talking about with just drugs. There's a lot of huge factors in here. And we're not going to send any loved ones home drug-free by thinking that we're just going to put them into a treatment facility and they're going to walk out the back door and their lives are going to get better. I wish it was that easy. Believe me, I do. But my concern is that until we actually do all those components, we run a real risk with this toxic drug supply. And, I'm saddened by it. And I see so many people struggling today, and it breaks me inside, but I care so much about them that I'm just going to be kind to them and hang out with them and just do everything I can to love on them. And in the hopes is that always give them the options that are available and advocate while they're in treatment to make sure that they have the proper supports when we get out. But that's non-existent in our society from coast to coast to coast.
Can we all agree that it would be a good thing if we invested more into recovery-oriented services?
I think it would be a good thing if we invested more into the things, preventing the things that drive people to accessing substances. I think for sure, enabling people and supporting people who have fallen into addiction need to be supported to be able to find whatever place on the recovery continuum works best for them. But I mean, I had a conversation, I hope I'm not speaking out of turn here, Guy, but I had a conversation with Guy where he was talking about the fact that there are treatment centers that there's no treatment centers that allow for people to use something as simple as marijuana. I can go to any strip mall in Calgary and I can pick up pounds of this stuff. And that's not a problem. But somebody who is navigating their way through incredibly complex trauma, and God knows what else, what other mental health pieces, it's going to be individual to every single person. They're not able to do that. You're not allowed to go to treatment if you're using something comparatively benign when you compare it to opiates, or to methamphetamine or. So to me, I think Guy's bang on when he said this is an incredibly complex problem. And the concern that I have with the people who are advocating for things like forced treatment or for getting rid of safe supply is you're approaching an incredibly complex problem that needs all hands on deck. All hands on deck. This is a brainstorming type situation where let's see what the ideas are. Let's throw as much as we can to support people and keep them alive. And if that means that some doctor makes some extra money because they got to prescribe a bunch of extra stuff, but 10 other people get to be alive to the point where they maybe get a chance to sort through what pushed them into addiction at the same time. Okay, that sucks. That doctor's a crook. We should deal with him later. But those 10 people are alive, and I'll take that as a win.
Yeah, I mean, I know this is an emotionally charged subject for a lot of us, myself included. But at the end of the day, for me, I just care about people, man. And I think one of my greatest things and I'm most passionate about is that educating the youth through the high schools. And these kids, a lot of these kids haven't even used substances yet, but they're struggling with the same things that I grew up with, which is the anxiety and the depression and the self-hatred. But these kids have so much awareness about it where I look to them, I'm just like, man, you guys are brilliant. Like, does anxiety ever go away? No. It hasn't in my world, but we do get better at managing it, and we can do things better than using something that can lead us to distractions. But I will say this is that I care a lot about them, and I hope, and this is why I share my story openly, is because listen, like the path that I once led is just a very painful road. And I'll continue to educate people on that in the hopes that they don't fall down the same path that I did. And if they do, then I'll still be there to support them, because I know that there's a lot of factors in why people struggle in our societies. Doing what I do, no matter what government's in power, it's not going to change what I'm going to do. It's like I don't get changed by what government's in there. I'm just me, and it's I pay it forward what was given to me, and a lot of people supported me through the darkest times of my life, and just a lot of people, random strangers, who supported me through the darkest times of my life, and I've never forgot those. And people always remember how you made them feel, and so I've never forgotten how many good people have come through my life trying to help it, and so that's what I'll continue to do today. So.
All right. We've gone past our time, gentlemen. I want to give each of you the opportunity to do some closing remarks, some closing thoughts. I want to be really clear. As much as this conversation did get heated, I would absolutely sit down for a Diet Cola with either of you. Some restaurants you can get Diet Coke. Some restaurants you can get Diet Pepsi. I would do either. I, however, live in Alberta. So, there's that. We'll give it to Adam to go first for closing remarks.
Okay, so I'll just say that I don't think that the people who advocate for safer supply are bad people. I think that they are deeply traumatized by all the death that they see around them, and that they are desperate for a solution, and they've latched onto this and think that it will help. And that there's been a lot of bad research which has suggested that it will help, but I really want to emphasize that safer supply is not the silver bullet that many people want it to be, and that there are significant gaps in the evidence behind this intervention, that there's a lot of unintended consequences that are quite harmful to people, and we need to be able to address that. And until we can have an honest conversation about the scale of diversion that is occurring here and how it could be driving additional addiction, then I don't think that's going to get better, right? And I really am going to focus going forward on educating the public about the scale of this problem, because every single stakeholder group who I've engaged with has validated its existence. And hopefully we can get to some kind of reform in the future. Hopefully we can get to a more responsible model, but this is where I'm coming from. And I feel like I have a moral obligation to do this. So I will keep on going in this path, much in the same way how Guy has emphasized that he will keep on going down this path. And hopefully through this tension, through this debate, we can get to a better place.
All right, Mr. Felicella, any closing thoughts you want to share?
Yeah, I mean, I I think, like I said, like constantly and consistently, we need a full spectrum of care. I support all pathways to recovery, including an abstinence-based approach. I'm abstinent for over 11 years. I also support harm reduction services such as safer alternatives, supervised consumption sites, needle exchanges, the whole gamut to, try to keep people alive. And my hope is out of all of this is that, including with Adam, is that, the smoking gun in our country is the toxic drug crisis. That is what's killing people. And that's what we really need to try to look at, to have a wealth of services that, try to do our best to remove people from that supply. Because, going into addiction treatment doesn't change that toxic drug supply. And when people go back out and use it again, that drug supply is there to ambush them and it'll destroy them. They won't have a chance. And so we just really have to work harder at addressing all those unaddressed societal issues, the complex challenges of, trauma, undiagnosed learning disabilities, housing, affordability, poverty. I mean, these are the things that are all involved in this thing. And it's not just get off your drugs and the life will get better. It's really, we have to get together, all groups across the country, and just sit down and target the exact specifics that need to be addressed to move forward. And if we do, we will save a lot of lives. And if we don't, well, I guess what, we'll just keep passing this on from generation to generation. And sadly, it'll just be always about the drugs and it won't be about anything else. And that's just be simply tragic. And I think one day Canada will look back on this time and say, what the heck were they doing? Because I think one day it will get figured out, because it's not going to get figured out the way that things are going.
There we go. I want to sincerely thank both of you gentlemen for taking your time for the conversation. For the record, Adam, I do not think you are a bad guy. I do not think you are evil. I don't think either of those things. And I think that it's one of the things that's really important is that we can be passionate about these issues and we can have our beliefs about these issues. But I think one of the things that's critically important, and I say this as I guess something of a clinician myself. I have such a hard time referring to myself as that because there's so many experts who know so much more about things than me. But as something of a clinician myself, I make my decisions when I'm dealing with people who are in crisis or who are experiencing some kind of injury, whether it's physical or psychological. I make my decisions based on the evidence. And sometimes, the scope of what I can do isn't enough to meet what they need fully encompassing, but I'll still do the things that I can do. And that's very much, again, how I view the safer supply conversation. If I come to somebody who's got a big arterial bleed in their leg, I'll put a tourniquet on. It'll temporarily solve the problem, but they need vascular surgery. And that's going to be a whole much longer thing than I can provide. And I want to be very, very clear. The view that I'm advocating for is not that this is safe supply is a silver bullet. I don't think, anybody who approaches something that has the depth and breadth of complexity that addiction, substance use, whether it's recreational or chronic, will do this one thing and that will make it better, is creating a system where people will fall through the cracks. And that's what I'm trying to emphasize in this conversation. I think there's absolutely room for certain types of safe supply. I think there's nuance to be had around other types of safe supply for sure. I think there's certainly, we need definitely more treatment spaces available. We need definitely more models of treatment spaces to be provided to people. But I think we also need to be open to the fact that some people, 50%, will never get to a place where they're never not using anything. They'll need to use something to get through the day. And I think that the place that we need to get to is to say, you know what? You're functioning better than you were. That's okay. It's one day at a time. And I think as long as we talk about these things like one side is talking about only a singular silver bullet, then we're doing a disservice to the whole conversation. I have no illusions, Adam, that you would like to see more treatment options available. And you've said yourself in the course of this conversation that you would like to see effective, safe supply. So I'm not looking at you going, oh, that guy he just wants to kill safe supply and that's it. That's not what I'm taking out of this conversation. And that's not what I've taken out of any of the conversations that I've had with you. That's what I have to say. So I want to thank both of you gentlemen. I got to do a bunch of housekeeping stuff. So I want to thank both of you gentlemen for taking the time to have this conversation. Adam, this is the first time that we've spoken face to face. Do with that what you will. But I really appreciate it. And I really appreciate you being open to the conversation and staying civil the entire time. I think you were probably more civil than me. So props for that. Guy, yeah, you know I love you. I mean, here's the thing. And I'm not in any way trying to be diminish who you are, Adam, or your body of work or anything like that. But I come from a very Henry Rollins punk rock type of background. If I was to take the coat off, you'd see all of the ink and everything. And people that I look up to and admire are Henry Rollins has an expression, knowledge without mileage equals bullshit. And when I think of people who I have encountered who have mileage, I am hard pressed to think of anybody with more mileage in this sphere and others than Mr. Felicella. So, Guy, I want to thank you so much for, again, taking the time to have this conversation. And I love that you take holistic as a word gets a lot of crap because there's a lot of quacks out there that use it, but it literally means let's look at the whole thing. And Mr. Felicella, you look at the whole thing. And I love the fact that you're just trying to save people's lives. And so thank you both. And I'm going to kick you out now because I got to do the housekeeping stuff.
Thanks for the show and for facilitating all of this.
Oh, you're welcome. So that's it for this conversation. Promised it was going to be spicy. I feel like it maybe was a little bit. Again, I want to say a big thank you to Adam and Guy for being willing to sit down and have what was going to be a bit of a corker. Now, I want to remind everybody, if you've made it this far, next Sunday, we are going to be presenting a rebuttal, a clinical rebuttal, an expert-based rebuttal. Maybe to Guy, maybe to me, maybe to Adam. I don't know. I do not have anywhere near the letters and the experience from a clinical standpoint as our guest, who's going to be Dr. Monty Ghosh. And I hope I'm saying that right. I haven't had the chance to have him correct me on that yet. I will be getting it at the beginning of our conversation. We're going to present that conversation on Sunday. And I'm really looking forward to it because he's literally going to go through this episode and he's going to say, hey, here's what you guys got right. Here's what this one of you got right. Here's what this one of you got wrong. And he's going to be breaking it down using the science and using the evidence because that's how we fact check on our show. We've got a bunch of other conversations that we're going to be presenting as well. We're going to be taking a look at the bigger expansion of private for-profit acute care. For those of you that follow the show, we just did an episode where we talked about the fact that there's a proposal that's been funded by the Alberta government to the tune of $85,000 to look at making the next, instead of giving Airdrie a hospital, they want to give Airdrie urgent care, Airdrie another urgent care, but they want to give them one that is for profit, privately owned and for profit. So that's a pretty big change to the healthcare delivery model in the province of Alberta. We're going to be having some more conversations about that as well. So we've got so much that we're going to be bringing you, and I would be absolutely remiss if I didn't say a huge thank you to all of our supporters, all the members of our audience. The chat tonight, Oh, this was nice because I didn't have to talk that much. I probably talked more than a lot of you wanted, but I didn't have to talk that much. So I got to follow the chat a lot closer tonight than I normally do. Huge thank you to everybody in the chat on all of the different platforms. I'm able to see all of the comments on all of the different platforms because of the software that we use. And it's our Patreon sponsors that pay for us to be able to use that software. So I also want to say huge thanks to our Patreon supporters. If you've enjoyed the show, if you enjoy the kind of content that we try to produce here, you can sign up to be one of our Patreon sponsors at www.patreon.com/thebreakdownab. But if you don't like the Patreon, you can just send us money. It's crass, so might as well just be crass. If you want to support the show, but you don't want to sign up for the monthly thing, then you can totally do that. You can send an e-transfer to info@thebreakdownab.ca. We are a registered company now, so it's all official and junk and tracked and all of that. We're in the process of trying to save up enough so that we can get our big fancy camera. We're very, very close, and you're going to see a whole new little side format come out as soon as we get to pull the trigger on that bad boy. And again, I just want to underscore what we talked about tonight is just a glimpse into the complexity of what is required to address the deaths of Albertans and Canadians. It is not a simple silver bullet approach. And anybody who is claiming that they have a simple silver bullet approach is lying to you. There are people who do their very, very best to go through the treatment process, and they still fall through the cracks. Anybody who follows the show knows that I did a thing a couple years ago where I talked about friends of my family, two parents of kids that my kids played with, who struggled with opioid use disorder. And they did everything that they could to get clean. And they did everything that they could to go to treatment. And they did go to treatment. And they did complete treatment. And only a few days after they got out of treatment, they both died from an overdose from the toxic supply. And this is why, one of many reasons, why I am so passionate about this is a complex issue that requires complex solutions. And we need to be supporting and refining all of the possible solutions that we can, but we cannot be further victimizing people who are dealing with any sort of substance use disorder. Because so often, the biggest reasons why they're using is because they're hurting from something already. And to further victimize them always only makes things worse. That's it for tonight. Thank you so much, everybody, for putting up with another 2-hour episode. And we will be back. Oh, I forgot Wednesday. I'm so bad at this. I'm so sorry. Wednesday. Oh, we've got a conversation for you. We are so excited. This is a hard turn, and I apologize for everybody here. On Wednesday, we have an extended conversation with bear experts. She's literally a bear expert. She has a PhD in bears. She's also an NDP MLA. And we have an extended conversation with her where we address the changes that have been made to make it so that any fool with a hunting license can try to take down a grizzly bear in the province of Alberta. It's a much lighter conversation than tonight, but it still has its moments. That's going to be Wednesday. Look for that. It'll be up hopefully tomorrow for our Patreon supporters. And that's all I got. Everybody, have a great weekend. Try to stay coolly if you can. And as always, keep the conversation going.